Go live.
Go live.
Dr. Mohammadi, you start.
السلام عليكم ورحمة الله
We are live.
وبركاته.
Wait, Doctor, we are live يا شباب.
We are live, Doctor. Go ahead.
Okay. السلام عليكم ورحمة الله وبركاته. I'm happy to be with you today in the annual Saudi Hematology Congress. This is the last day, and I hope that we will all benefit from all of the important information that we will get today. It is my great honor to introduce our two moderators for session 1 and session 2. For session 1, it's Dr. Murtada Ghabouri. He's an associate professor and senior consultant hematologist at Sultan Qaboos University Hospital in Oman. His area of interest are malignant stem cell disorders, acute leukemia, and bone marrow transplantation. The second moderator is Dr. Hazzaz Zahrani. He's a consultant and head of hematology and stem cell transplant at King Faisal Specialist Hospital in Riyadh. So from here I will hand my microphone, and thank you very much.
Thank you, Dr. Mohammadi, for the introduction. And I would also like to thank Dr. Marwan, Dr. Firas, and the other organizers for the invitation. Today is day 7. It is about benign hematology and transfusion medicine. In this session, we will have 3 talks. It is my pleasure to introduce the speakers here. Each talk would be about 25 minutes. We would love to have questions. We would love to have interactions. As they come, please, as participants, put them in the Q&A, and we will discuss them at the end, inshallah. It is my pleasure to introduce Dr. Thomas Ortel. Dr. Thomas Ortel is the chief of the Division of Hematology at Duke University Medical Center. He's a professor of medicine and pathology, and he's the director of the lab-based research for the Department of Medicine. He also serves as a director of the Duke Hemostasis and Thrombosis Center, director of the Duke Anticoagulation Clinic, and the medical director of the Clinical Coagulation and the Platelet Antibody Laboratories at Duke. He would talk to us for the next 25 minutes on the new indications for the DOACs. Dr. Ortel, the mic is yours.
I'd like to thank the organizers for inviting me to talk here today on the new uses for the direct oral anticoagulants. My name is Tom Ortel. I'm from Duke University in North Carolina in the United States. The direct oral anticoagulants are a class of agents that target a specific clotting factor, and there's 4 anti-factor Xa agents approved in the US, 1 antithrombin agent. Currently available in the US are only 3 of the anti-factor Xa agents. These drugs have now been around for over 10 years and have been finding an increasing number of uses. These are the currently approved indications and approved drugs in use in the United States. All of them have been approved for atrial fibrillation stroke prevention. All of them have been approved for treatment of VTE. 3 of them have been approved for extended treatment periods of venous thromboembolism, and 3 of them have been approved for orthopedic procedures. Now, there's also a number of off-label uses that these drugs are employed in, including, for example, with rivaroxaban, acute coronary syndromes after stabilization with initial management, HIT, acute symptomatic superficial venous thrombophlebitis, and venous thromboembolism prophylaxis after a non-major orthopedic procedure. Apixaban is also used in HIT and prevention of recurrent stroke and TIA in patients with MI. But what about new uses? What's coming along? What are people looking for? So we're always looking for treatments for venous thrombosis in unusual locations. And let's start with cerebral venous thrombosis. Here, there has been published a couple years ago an exploratory prospective randomized parallel group, open label, multi-center clinical trial that looked at dabigatran etexylate in patients with cerebral venous thrombosis. And the trial design is shown here. It was a screening and diagnosis period, after which the patient received a parenteral anticoagulant for 5 to 15 days, and then were randomized to either dabigatran or warfarin for 6 months with follow-up 7 days afterwards. And what this trial showed, trial was known as RESPECT CVT, was that for the primary outcome, which was the combination of major bleeding or venous thrombotic event of any kind, dabigatran etexylate and warfarin were essentially equivalent. Secondary outcomes similarly, as well as secondary safety outcomes, there was no evidence for increased bleeding. And this allowed the authors to conclude that patients who had cerebral venous thrombosis could be anticoagulated with either dabigatran or warfarin, and they had a low risk of recurrent venous thromboembolism and a risk of bleeding that was similar with both medications, indicating that dabigatran at least could be used in patients with cerebral venous thrombosis. What about splanchnic vein thrombosis? This is another area that we see a lot of patients with, and can we use these drugs there? This was a paper that was published last year. It was a retrospective review of over 300 patients with non-cirrhotic portal vein thrombosis over almost a 20-year period. The primary outcome here was not clinical symptoms or clinical evidence, but it was a radiographic imaging improvement of the portal vein thrombosis established on follow-up imaging. And what the authors were able to show was, on this slide, you can see this dark blue line here. This is any direct oral anticoagulant. Enoxaparin is in green, and this is showing the probability of resolution of the portal vein thrombosis. You can see that the DOACs as a class were as good as enoxaparin, both of which were better than warfarin, which was in the purple line. And obviously the red line shows that you do get some low rate of spontaneous resolution, but it's very low, indicating here that the DOACs looked as good as the low molecular weight heparin, which is the drug that we use most commonly. And what about cirrhotic portal vein or cirrhotic splanchnic vein thrombosis? There have been several studies that have been published, all of which are small or retrospective, but they have looked at the antithrombotic treatment with direct oral anticoagulants in patients with splanchnic vein thrombosis and cirrhosis, the DOACs in chronic portal vein thrombosis in patients with hepatic cirrhosis, and there was even a small controlled trial of rivaroxaban versus warfarin in the management of acute non-neoplastic portal vein thrombosis. All of these small studies suggest that this drug will be useful in this patient population with cirrhotic splanchnic vein thrombosis, but none of them are really strong definitive data, but they are suggesting that appropriately a trial should be done. But in the meantime, these drugs are options that could be used. Now, the interesting thing also about this is that as these began being used in patients with cirrhotic splanchnic vein thrombosis, the question became, well, what would you do if you wanted to list this person for transplantation? And with the development of the reversal agent for dabigatran, idarucizumab, there have appeared several small case reports of patients who had an indication for an anticoagulant being maintained on dabigatran, and then when they needed to have their liver transplant, the dabigatran would be reversed with idarucizumab, allowing then kind of a safer option for how do you perioperatively or peritransplant manage anticoagulant therapy in these folks with portal vein thrombosis. This soon then became applied in patients with cardiac transplant surgery as well as lung transplant surgery. And most people are leaning towards using the combination of dabigatran and idarucizumab. There is some concern that if you use an anti-10A agent and try to reverse it with andexanet, you might have thrombosis. This is something that's hypothetical and needs to be studied further, but this does give an option for the transplant patient population. Now, what about cancer-associated thrombosis. Okay, there's been a lot of data in the last few years on cancer-associated thrombosis. There's 4 prospective randomized trials that have looked at it. The first one that appeared was the Hokusai VTE cancer study. This was an open-label, non-inferiority design trial that studied adult patients with objectively confirmed cancer who had either symptomatic DVT or PE or an incidentally identified DVT or PE, and incidentally identified PE had to be at least segmental. They were treated with a low molecular weight heparin for at least 5 days, and then randomized to either edoxaban or dalteparin, with a primary outcome being a composite endpoint of recurrent clots or major bleeding. And what they were able to show was that if you looked at either dalteparin or edoxaban for that composite outcome endpoint, the outcomes were similar. There was no difference between dalteparin and edoxaban, so it was non-inferior for the primary endpoint. Interestingly, if you looked at the individual endpoints, however, the secondary endpoints, you can see on here that there was an increased risk for a recurrent thrombosis in patients on the dalteparin arm compared to edoxaban, but what you ended up having was an increased risk of major bleeding in the bottom panel on the right with the edoxaban arm versus dalteparin. So it was interesting that the composite outcome showed non-inferiority. There are some differences, however, that you need to be aware of if you look at the individual components of that composite endpoint. And the conclusion that the authors drew was that oral edoxaban was non-inferior to subcutaneous dalteparin with respect to that composite outcome, but you might want to use caution in patients who you're worried about are at higher risk for bleeding. Now, shortly after this trial appeared, the Select D trial appeared with rivaroxaban, and then the ATOM VTE and Caravaggio trials appeared with apixaban. And once these 4 trials appeared, Caravaggio just earlier last year, then all of a sudden there were a total of 7 systematic reviews and meta-analyses that appeared. So there was almost a feverish rush to get this out there. And these all differed a little bit in their design. They all differed a little bit in the number of patients analyzed, but all of them showed similarly that VTE recurrence was decreased with the direct oral anticoagulant compared to the low molecular weight heparin as the control. Major bleeding was slightly increased in all of them, although it was not statistically significant. Clinically relevant non-major bleeding was also increased and was significant in a subset of the analyses. All of these ended up suggesting that in patients with cancer-associated VTE, the direct oral anticoagulants are a reasonable alternative or different option that you could use. And really, most of the guidelines have now moved towards recommending the direct oral anticoagulants up front as the recommended treatment for patients with cancer-associated venous thromboembolism over low molecular weight heparins. Now, what other uses are people looking at for patients with thrombotic events? And here, there's also a very strong interest in identifying whether or not the direct oral anticoagulants might provide some additional benefit in patients with arterial thromboembolic events. Mostly for the longest time, antiplatelet agents have been primarily the agent used in patients with arterial thromboembolic events, unless you think it was related to atrial fibrillation. But for peripheral arterial disease, it's usually been antiplatelet therapies. The COMPASS trial was a series of studies that have looked at the use of a low-dose direct oral anticoagulant combined with or in place of antiplatelet therapy in patients with a variety of arterial diseases. And this study that I'm going to talk about that appeared in Lancet in 2018, COMPASS, looked at patients with stable peripheral arterial disease or carotid disease. It was a multi-center, double-blind, randomized, placebo-controlled trial where patients had to have a history of peripheral arterial disease or carotid artery disease, or they could have coronary artery disease, but they had to have an ankle brachial, ABI, ankle brachial index of less than 0.9. So they had evidence of peripheral vascular disease as well. The primary outcome was cardiovascular death, MI, or stroke. There were a number of secondary outcomes, also including limb outcome. So whether or not people lost a limb or had to have revascularization on a limb. The trial design is shown here. For this particular study, there was a run-in period to ensure compliance with participation on the study. And then patients were randomized to aspirin, which was considered the standard of care daily, or rivaroxaban 5 milligrams twice a day, or rivaroxaban 2.5 milligrams twice a day with aspirin daily. So noting that not only were these doses lower than what we use for venous thromboembolism or arterial thromboembolism, but it was also a different dosing strategy, spreading it out to twice a day instead of once a day. What this study showed was that compared to aspirin, this is the cumulative incidence risk of that arterial thromboembolic event outcome, the combination of cardiovascular death, MI, or stroke. You can see here that aspirin alone actually had the highest likelihood of this composite outcome, and rivaroxaban plus aspirin, that 2.5 twice a day with aspirin, actually was lower, and this was statistically significant decrease. Rivaroxaban alone, the 5 milligram twice a day, also trended lower, but it was not statistically significant. But what if you looked at limb outcomes? Limb outcomes had the same direction in that patients with aspirin alone had a higher incidence of that outcome compared to either of the rivaroxaban arms, both of which were statistically significant in this particular study. Again, with the rivaroxaban plus aspirin versus aspirin alone being better, suggesting that you can combine a low-dose direct oral anticoagulant with aspirin to get a better outcome. However, the trade-off is that there is an increased risk of major bleeding. And you can see here either the low-dose rivaroxaban plus aspirin or the rivaroxaban alone versus aspirin alone had an increased risk of major bleeding. This was not fatal bleeding. It was not intracranial hemorrhage, but what was statistically significantly different was other types of major bleeding, including surgical site bleeding requiring reoperation or bleeding leading to hospitalization. Their conclusion from all of this was that low-dose rivaroxaban taken twice a day plus aspirin once a day reduced major adverse cardiovascular and limb events compared to aspirin alone. Major bleeding was increased, but fatal or critical organ bleeding was not. So you could consider this in a patient who might have a low risk or who would have a low risk of bleeding. The COMPASS investigators have also looked at other types of things, such as after myocardial infarction and other arterial types of thromboembolic events, and all of them have this combined increased risk of bleeding when you start looking at combining a DOAC with aspirin compared to aspirin alone. Now, what about cardiac valves? Okay, everyone here recalls the REALIGN study, which was the study that appeared a number of years ago now. It was a phase 2 dose validation study that compared dabigatran versus warfarin in patients with prosthetic aortic valves or mitral valves. And what they showed was that dabigatran was associated with an increased risk of having a thromboembolic event. So this is probability of no event. You're less likely to have no event with dabigatran. So you're more likely to have a thrombotic event, and you're more likely to have a bleeding event with dabigatran. So that pretty much removed the direct oral anticoagulants from comparison to warfarin for most patients with prosthetic valves. However, it leaves the question open of whether or not a DOAC might be of benefit in patients with bioprosthetic valves or some of the newer design valves. In particular, RIVER was a multi-center randomized non-inferiority design study. It was a probe design, meaning open label, but with blinded adjudication of outcomes that looked at patients who had permanent paroxysmal or persistent AFib or flutter and a bioprosthetic mitral valve, okay, a tissue mitral valve, and who were going to receive anticoagulant therapy. And they were randomized to get either rivaroxaban at standard dosing or warfarin with a target INR of 2 to 3, with a primary outcome that was a composite of death, major cardiovascular events, or major bleeding at 12 months. And what RIVER showed is that there was actually a slightly decreased risk of that composite outcome for the rivaroxaban compared to warfarin, and it did meet statistical significance for non-inferiority with this combined outcome. So in conclusion, patients with AFib who have a bioprosthetic mitral valve, rivaroxaban was non-inferior to warfarin with respect to the mean time until primary outcome. So therefore, rivaroxaban could be used in this subset of patients. Now, what about a prosthetic, a truly prosthetic valve? Here, there is actually a study that's currently ongoing that I want to let you know about because it will appear at some time soon, I hope, is the PROACT 10A trial. And this is a randomized multi-center open label study that's looking at patients with what's called the Onyx aortic heart valve or an Onyx aortic valve prosthesis with a particular vascular graft. Now the, excuse me, the Onyx valve is shown here. This is a relatively new valve that's been studied in a number of indications and actually has been shown to be less thrombogenic than other valves. And it's being put in the aortic position, which is also a less thrombogenic location for a valve to be inserted. So therefore, what the investigators for this trial are doing are taking patients who have an Onyx aortic valve, not mitral valve, just the aortic valve. They've had it in place for greater than 3 months, 1,000 total individuals they're looking for. You're going to randomize them to either apixaban 5 twice a day or continued warfarin with an INR goal of 2 to 3 with a 2-year follow-up. The primary endpoint is going to be a composite of valve thrombosis and valve-related thromboembolism. And this trial is currently open. I think it's an important trial that we explore and investigate as far as utility of the DOACs in this particular population. Now, what about special populations? Well, a key one is the pediatric patient population. And here there have been a number of trials that have looked at the direct oral anticoagulants in pediatric patients. Einstein Jr. was one of the first ones. This was a multi-center study at 107 hospitals, 28 countries, targeting children less than 18 years of age, initially treated with unfractionated heparin, low molecular weight heparin or Fonda, and then randomized to rivaroxaban or standard anticoagulant therapy. Primary outcome was symptomatic recurrent VTE with a safety outcome of bleeding. As you can see on here, this is the primary data slide. For the primary efficacy outcome, there was no increased risk of recurrent thrombotic events, and in the safety events, there was no increase in major or clinically relevant non-major bleeding, leaving the conclusion that in children with acute VTE, treatment with rivaroxaban had a low recurrence risk, as well as no increase in bleeding compared to standard anticoagulants, indicating that it could be used in these patients. Similarly, what appeared earlier this year is the Diversity trial, which was another randomized controlled open label study. It was a phase 2b/3, enrolling patients less than 18. Initial treatment with a parenteral anticoagulant followed by randomization to dabigatran versus standard of care, which in most cases was vitamin K antagonists. Here, the primary composite outcome was proportion of children with complete thrombus resolution, as well as freedom from recurrent VTE and VTE-related death. And what they were able to show, freedom from recurrence is shown here, with dabigatran etexolate being better than the standard of care on this graph, trending towards improved outcome. And if you look at any bleeding, you can also see here that the dabigatran in red was comparable to the warfarin in blue, leaving the conclusion that dabigatran was non-inferior to standard of care in terms of efficacy with similar PK-PD relationships as in adults, giving pediatric treaters another option as well. So dabigatran also has been used in peds patients. What about new uses? What about the DOACs in outpatients with COVID-19? And here I'm going to tell you just about 3 studies that are currently open and enrolling that we hope will find out if they can help prevent thrombotic events in the non-hospitalized cohort of patients with COVID-19. The first one is Active 4B. This is currently open. It's a multi-center trial that's looking at antithrombotic strategies in patients with COVID-19 who are not sick enough to be in the hospital. It is enrolling folks who basically have had COVID-19 diagnosed in 14 days, non-thrombocytopenic, not in renal failure. and randomizing these folks to placebo, aspirin, apixaban at a prophylactic dose, or apixaban at a therapeutic dose, following these folks for a composite endpoint of symptomatic VTE, arterial thromboembolic events, hospitalization for cardiovascular events, and all-cause mortality at 45 days. Another trial also looking at rivaroxaban is the Prevent HD. This one is also open and enrolling. It's randomizing folks to placebo versus rivaroxaban at a prophylactic dose for a total treatment period of 35 days and follow-up at 35 days and 49 days. Again, looking for decreased outpatient thromboembolic events. The last one to mention is the Active 4C. This is a multi-center adaptive trial that's looking at extended thromboprophylaxis for 30 days following discharge. So the patient who's been in the hospital and is going home is going to get randomized to look at whether or not extended thromboprophylaxis should be used. This study is also looking for 18 years of age and older, COVID-19 positive, hospitalized for 48 hours or more. They don't have to have an anticoagulant of some kind, and they don't have an absolute contraindication, and they're getting randomized to either apixaban 2.5 twice a day or matching placebo. And this study is going to stratify based on whether or not somebody was in an ICU setting by using the WHO ordinal index score. We're also including people who are going to be on antiplatelet agents when they go home as well. And this study is looking at the composite endpoint of venous thromboembolism, arterial thromboembolism, and death at 30 days after randomization. Now, to close, are DOACs the answer for all situations? Well, we do have studies that have shown that they don't work for everything. I think that prosthetic cardiac valves, you have to be careful. Clearly, the Realign demonstrated that dabigatran was associated with increased events. Currently, with prosthetic cardiac valves, we need to use warfarin in these folks until we have a study. Triple positive antiphospholipid syndrome has been studied in a couple of studies and shown to also require warfarin over a direct oral anticoagulant. End-stage renal disease is an area that you need to use with caution, and one that I don't have on here that I think needs to be also explored is whether or not we could use any of the direct oral anticoagulants in the pregnant patient population. That is something that definitely needs to be studied, however, and currently we only have low molecular weight heparins for that group. So in conclusion, anticoagulant therapy is used in a wide variety of clinical settings and diverse patient populations and being explored in more and more settings. It offers innovative approaches, alternative strategies for many of these situations, including use of really low-dose DOACs, potentially combined with antiplatelet agents. I think that the future directions, we're going to see an expanding role for the use of these novel approaches, as well as introduction of combination strategies that might be very interesting and useful. Again, modifications of this low-dose DOAC and antiplatelet therapy, can we adjust the doses to decrease the bleeding risk? And on this side, I show my disclosures. The only one that really is relevant here is that I am the study chair for the Active 4C, the extended thromboprophylaxis trial that I talked about briefly, which is funded by the NIH. Otherwise, none of these are directly relevant to my talk today. And I thank you very much for your attention, and happy to address any questions or thoughts that you might have.
The participant who is listening to us now And just to mention that all the question and answer will be at the end of the first session.
Thank you, Dr. Ortel. Very nice, informative, excellent talk. Now, it is my pleasure to introduce Dr. Armando Tripodi. Tripodi is a full professor of clinical biochemistry at the Faculty of Medicine in Humanities, University, Milano, Italy. His research is mainly focused on elucidation of coagulation mechanisms, lab diagnosis of coagulation disorders, standardization and quality control of coagulation tests, and lab control of anticoagulant treatment. He would talk to us on the coagulation changes that we see now with adults with COVID-19. It's also important to mention here that we've reached over 4,500 attendees in this session. I thought benign hematology would not compete with malignant hematology, but this is defeating my assumption. It is my pleasure to give the mic to Prof. Tripodi.
The chairman. I wish to thank the organizers for this kind invitation to be here with you this evening. And during the next 20 minutes, I will talk about the coagulation changes in adults with COVID-19. I cannot move my slides, actually. Okay. These are my disclosure. I wish to start my presentation sharing with you this graph, which represent the time course and the severity of COVID-19. I cannot see my slide now. Can you start again my slides, please? Can you hear me now?
Yes, now we can hear you. You can
Okay.
you can see the slides now, right? Because we
Okay.
can see them. Yeah, then you can go ahead. I'm sorry about this.
Okay, can I start again?
Yes, please. You can start.
Okay. So I was illustrating this graph, which represents the time course and the severity of COVID-19. And as you know, the first occurrence in COVID-19 is the viral response, which is typically very high, very strong at the beginning, and then they start to decrease over time, as you can see here. On the other hand, the host-inflammatory response is exactly the opposite, as you can see here. It starts to be relatively mild at the beginning and then increase over time. On the top of this, we have the hemostasis alterations, which typically are very mild at the beginning and they start to increase over time. So whenever you interpret the results of hemostasis test in patients with COVID-19, you should take into account the stage of the disease where the patient is located at the moment. Otherwise, interpretation is quite difficult. Now, we know very well that the majority, if not all, the hemostasis abnormality which occur in patients with COVID-19 are due to high plasma levels of pro-inflammatory cytokines, which are observed in this patient, particularly in those admitted to the ICU. These pro-inflammatory cytokines are able to promote considerable derangement of hemostasis and also endothelial perturbation, which may lead to fibrin deposition and eventually to vascular occlusion, as it had been observed in these patients. It's difficult to find some information about the incidence of thrombotic event in COVID-19 patients because the information are very sparse. I would like just to mention this article, which is a meta-analysis, a recent meta-analysis of venous thromboembolism incidence in patients with COVID-19. And the authors here looked at the 30 studies with a huge number of patients, as you can see here, and the estimation was pulmonary embolism account for 12% up to 17% of cases, and DVT, the median value, the incidence was 14% up to 23%, as you can see here. So a considerable incidence of VTE in patients with COVID-19. At the very beginning of the pandemic, some Chinese colleagues published this study on abnormal coagulation parameters, and they reported that these abnormalities are associated with a poor prognosis in patients with COVID-19. And actually, they investigated a considerable number of patients, more than 180, as you can see here, and 21 were non-survivors. When they looked at the different results, the prothrombin time, pardon, can you hear me?
Yes, we can hear you. Can others please mute themselves?
Okay.
You can go ahead.
Okay, thank you. So the prothrombin time in this patient was a bit prolonged, as you can see here, but was slightly more prolonged in the non-survivors, as you can see here, a few seconds more. And the fibrinogen was elevated in all the patients, but was much higher in those patients who did not survive, as you can see here. And the same is valid for the dimer, which was elevated, but more elevated in those patients who were non-survivors. And the same conclusion is for the FDP, which has been measured in that study. The second study published in JAMA Internal Medicine by Chinese colleagues is this one, which has been published a few months later than the first one. And in this study, the authors investigated by bivariate Cox regression analysis those factors which seems to be associated with the progression of the disease to IRDS or death. And as you can see here from the hazard ratio, IL-6 was associated with the progression of the disease to IRDS and death, as you can see here, statistically significant hazard ratio. The prothrombin time was apparently associated with the progression to IRDS, but not to death, as you can see here. And the APTT was neither associated with the progression to IRDS nor to death, as you can see here. And finally, D-dimer was strongly associated with both progression of IRDS and death. And I think these results were the first to give some value to, particularly to D-dimer. There were some other papers publishing information on D-dimer. This one was on the utility of D-dimer in predicting venous thromboembolism, non-mechanical ventilated COVID-19 survivors, as you can see here. The authors here investigated different values of D-dimer to see whether they were predictor of venous thromboembolism. And as you can see here, the group of patients who had D-dimer more than 1 but less than 2 micrograms per ml had an odds ratio for VTE, which was 2.3 and was not statistically significant, as you can see here. But those patients with a D-dimer more than 2 but less than 5 had an odds ratio for VTE, which was close to 3, as you can see here, and was statistically significant. And finally, those patients with elevated levels of D-dimer amounting to more than 5 micrograms per ml had an odds ratio for VTE, which was close to 11 and was statistically significant. There was also a recent paper published on a Saudi multi-center study in Saudi Arabia. And here the authors found that the baseline D-dimer, as you can see here, is a risk factor for VTE with an odds ratio of 1.3, which was statistically significant. And also the baseline D-dimer in this study was a risk factor for composite events, as you can see here. The odds ratio 1.3 and was again statistically significant. Now, all this information on the D-dimer should be taken with caution because they stem from a retrospective analysis. And by definition, retrospective analysis cannot distinguish between the causes and consequences for these parameters. So I think that D-dimer is very relevant apparently in the studies, but we should wait some results from prospective studies before D-dimer can be used for patient management. A few weeks later than the papers published by our Chinese colleagues, we started investigating our patient in Italy at the beginning of the outbreak. And we investigated particularly hypercoagulability in patients who were admitted to intensive care unit and reported some thromboelastography findings and other parameters of hemostasis I would like to share with you. For those of you who are not very familiar with viscoelastometry, I would like to show this tracing, with typical tracing of viscoelastometry, which is characterized by different parameters. The clotting time here, the clot formation time, which gives you information about the velocity of clot formation, and finally, the maximal clot formation, which gives you information about the maximal amplitude of the clot and its firmness. Now, you see here two typical viscoelastic tracing we found in our patient population. The solid line here represents the tracing from a COVID-19 patient, and the broken line here represents the tracing of an healthy subject. So you can see that the maximal amplitude of the clot formation is much higher in patients with COVID-19 than in the healthy subjects, and this denotes hypercoagulability in these patients. When we looked at the individual results, the distribution of individual results of the maximal amplitude in our patient population, we found, as you can see here, that the majority of patients had maximal amplitude levels which were higher than the mean of the normal range. And again, this denotes a state of hypercoagulability detected by thromboelastometry. Another group of research workers in Italy published more recently their paper in which they investigated the thromboelastometry profile by using another device which is commercially available. We used the ROTEM, we used TAG, they used the ROTEM, and as you can see here, the pattern of results were similar. Patients were hypercoagulable, as you can see here, regardless of whether the viscoelastometry was performed as INTEM, EXTEM, or FIBTEM, as you can see here. So, in summary, it seems that the viscoelastic parameters denote hypercoagulability in patients with COVID-19. More recently, we carried out another study in which we investigated hemostatic alterations in COVID-19. This is the front page of the paper published in Hematologica, and I take the opportunity to thank all the colleagues which are listed here who contributed to this collection of results. The aim of the study was relatively simple. We wanted to see the extent of hemostatic abnormalities, but also to see whether these abnormalities progress with COVID-19 severity. And to this end, we investigated nearly 70 hospitalized patients who were divided according to the intensity of treatment care, defined as low, intermediate, and high. And low intensity treatment care are those patients who required ventilation support only. In the intermediate treatment care, we included patients who required continuous positive air pressure with CPAP. And finally, in the eye, we included patients who required intubation and mechanical ventilation. We investigated on these patients a vast array of hemostatic parameters, subdivided here as the IC parameters, which included the prothrombin time, platelets count, fibrinogen, and D-dimer, pro and anticoagulant parameters, including factor VIII, antithrombin, protein CNS, endothelial parameters, including von Willebrand factor and Adams-13, and finally, inflammatory parameters, including C-reactive protein and ferritin. Let's look at the results of the IC parameters, as you can see here. These are the results of the prothrombin time, the distribution of results in the three groups. As you can see here, the majority of patients had the prothrombin time ratio, which was quite normal. The range of the reference range is shown here by the red broken line, as you can see. The platelet count you see here, the vast majority, in the majority of patients, the platelet count was higher than the upper limit of the normal range. And also there was a close correlation between the three groups of patients as far as platelet count is concerned. Fibrinogen is shown here, and again you see that in the majority of patients, fibrinogen was elevated, was much higher than the upper limit of the reference range. And even here, there was a close correlation between the three groups of patients. And finally, the other parameter which is relevant for the IC is the D-dimer. As you can see here, all the patients had the D-dimer levels which were higher than the upper limit of the reference range. And even here, there was a very good degree of correlation between the three groups. Now, we know that according to ISTH criteria, to define overt DIC, we need to look at different parameters, which are PT prolongation, low platelet count, low fibrinogen, and the dimer. Now, if you consider our results and also other results published by other authors, you see that among the hemostatic parameters, only elevated D-dimer seems to be consistent with overt DIC in COVID-19 patients. And this contrasts with the earlier paper published by our Chinese colleagues in which they determined that the patient had DIC. What about the pro and anticoagulant parameters? These are the distribution of results of factor VIII activity. You see that the majority, I mean, all the patients had factor VIII activity, which was much higher than the upper limit of the normal range. And also there was a very close correlation between the three groups. Antithrombin was quite normal in the majority of patients, as you can see here. And protein C was normal in some of the patients, but unexpectedly in the group, in the high group patient, the median level of protein C was quite high, as you can see here. It was close to 150%. Protein S was quite normal in all patients, as you can see here. And so, in summary, from this observation, we can draw the conclusion that the pro and anticoagulant parameters are consistent with hypercoagulability in this cohort of patients. Then we investigated also endothelial parameters, and here we looked at the von Willebrand factor and the Adams 13, which is the protease which is able to degrade von Willebrand factor, as you know. These are the results, the distribution of results of von Willebrand factor antigen in the three groups. And again, you see that all the patients had von Willebrand factor antigen, which was much higher than the upper limit of the normal range. And again, there was a very close correlation between the three groups. These are the results of the ristocetin cofactor activity in the three groups of patients. Again, even ristocetin cofactor was elevated much more than the upper limit of the normal range. And again, there was a very good correlation between the three groups. When we looked at the ratio between ristocetin cofactor and antigen, we found that the majority, all the patients, as you can see here, had a ratio which was lower than the expected unity. And this means that most of the von Willebrand factor antigen molecules are probably dysfunctional in this cohort of patients. What about Adams 13? You see here the distribution of results in the three groups. In the first group, in the low group, Adams 13 was relatively normal, as you can see in most of the patients, but in the intermediate and the high group, Adams 13 started to decrease considerably, and you see that there was a good correlation between the three groups. What about the ratio between von Willebrand factor antigen and Adams 13? As you can see here, this ratio was higher than the expected unity in all the patients, and there was a very good correlation between the three groups in increasing levels of this ratio, which amounted to 3.4, 6.8, and 8.3 respectively in the three groups of patients. There were some other papers published over time in the literature in which the authors looked at whether Adams 13 could be useful just to predict mortality in patients with COVID-19. This is one of these papers, and you see from the Kaplan-Meier curve here that the authors concluded that those patients who had Adams 13 levels less than 70 units per deciliter had a poor survival, as you can see here. Another paper was soon later published in this respect, and you see again that here the authors concluded that those patients who had Adams 13 less than 30 units per deciliter had a poor survival, as you can see here. Now, as I mentioned for the dimer, also for Adams 13, we should think about using this value, these results for patient management, because again, these values have been obtained in retrospective observations, and therefore, again, here it's not possible to distinguish causes from consequences. So I think that in the future, we should, I would say, organize prospective studies to see whether both D-dimer but also Adams 13 could be useful in patient management. So in summary, from these results, we can derive the conclusion that von Willebrand factor levels are consistent with a certain degree of endothelial perturbation in patients with COVID-19. What about inflammatory parameters? These are the distribution of results of C-reactive protein, as you can see here, all the patients had C-reactive protein, which was higher than the upper limit of the normal range. And again, close correlation between the three groups, and the results are similar when we looked at the ferritin, as you can see here. Now, I can go to my conclusion. I think that these results are really reliable in telling us that COVID-19 presents with the considerable derangement of hemostasis, and this may vary according to the disease progression, and that's why it's important to take into consideration the stage of the disease where the patient is located whenever you interpret results of hemostasis in your patient population. And the second point is that abnormalities seems to be not consistent with over the IC and consumption coagulopathy as was previously reported. And finally, it seems that patients possess an evident state of hypercoagulability and endothelial perturbation, which might be responsible for the thrombotic events which have been found in these patients. There are some key issues which require urgent attention, and I think from now on we should start investigating these issues. For instance, we should start an accurate collection on the clinical presentation of any hemostasis abnormality in these patients. And I know there are, I'll say, many ongoing registry which are collecting this data, and I think the analysis of this data will give us the opportunity to derive some information for patient management. And also, the same is valid to define the usefulness of hemostasis parameters, for instance, as I mentioned, D-dimer, but also Adams 13 in decision-making. We should organize prospective study for this. And finally, probably it is most important to organize randomized clinical trials in order to assess the effect of anticoagulation on the outcome of critically ill patients, and also, probably more important, the value of a more intense thromboprophylaxis to improve morbidity and mortality in hospitalized patients. You know, at the moment, this area is really not very well explored because some clinical trials have been initiated, but actually at the moment there are no results. So I think that in the next future we'll know much more on this aspect. I stop here and thank you very much for your attention.
Thank you, Dr. Taipoli. Clear and comprehensive. We would leave the questions and answers towards the end as we previously planned. And we apologize for the technical problems. Now, it is my pleasure to introduce Dr. Flora Pivandi. Dr. Pivandi is a full professor of internal medicine at the University of Milan, Italy. She is the director of internal medicine, hemostasis and thrombosis unit of the IRCCS Maggiore Hospital and director of the Angelo Bianchi Bonomi. I hope I did it well. Well, I know a little bit Italy, like zero. She's also a hemophilia and thrombosis center at Milan. Her research is focused on the investigation of the molecular mechanisms of coagulation disorders and on the immunogenicity of the coagulation products. She'll talk to us on in the next 25 minutes on the diagnosis and management of rare bleeding disorders. Prof. Pivandi, the mic is yours.
Can you hear me?
We can hear you now.
Okay. Good evening to everyone. Thanks very much for your kind presentation. Actually, it's a kind of pain to have a presentation for Saudi friends from here and not being video and doing the Umrah with you. And I hope soon we can have a face-to-face meeting and to
Prof, you're muted again, I think. Prof. Vivandi, I think we lost her. Ayman, can you help out? Prof. Vivandi, can you?
Still, we cannot hear Dr. Flora.
Marwan, can we then do
or technical support? Yeah. What about taking questions till she joins?
Yeah. So maybe we can start with Dr. Tripodi, sorry.
Yes.
We'll start with one question. When is the maximum risk of a thromboembolism in the stages of COVID-19?
I think that the risk is elevated during the post-inflammatory response, because there you start having the inflammatory response, which is quite high, with the I would say circulation of cytokines in the plasma, which can be responsible for the arrangement of both pro and anticoagulants and also fibrinolysis. So I think that's at that time point, the risk is relatively high.
Okay, and then maybe if Dr. Ortel is around, we can alternate questions till Prof. Vivandi comes back. Is Dr. Ortel around? Or?
Yes.
Maybe we can alternate the questions. So why the DOACs failed to be the winner in the valves, while consistently they were the winner in many other indications? Is there a different pathophysiology there with the valves than we don't see it in others conditions?
Most likely that is going to be the cause. Very similarly with triple positive antiphospholipid syndrome, that there's probably something different about the pathophysiology. With the direct oral anticoagulants, you are only getting a single one of the prothrombotic enzymes actually targeted. And whereas with warfarin, you are lowering actually 4 different vitamin K proteins. The interesting concept would be whether or not we ever get to the point where we actually consider combining different DOACs. For example, could you combine a low-dose anti-10A and an antithrombin to see what kind of effect that you might get? But at this stage anyway, at least with the one drug that was investigated, it was not sufficient in that patient population.
Maybe a follow-up question on a related topic on the arterial thrombosis. You've shown that probably the rivaroxaban is better than aspirin, but does the addition of aspirin to the rivaroxaban compared to rivaroxaban alone add much of benefit?
Which patient population are you talking about?
When we're trying to prevent the arterial thrombosis, the study that you
arterial thrombosis. So the COMPASS study. The COMPASS study, it looked like, at least in for those patients with peripheral arterial disease, it was the combination of that low dose direct oral anticoagulant with the aspirin that seemed to be the most efficacious or effective at preventing outcomes. It was associated with an increased risk of bleeding, but it was the best option for preventing recurrent thromboembolic events, at least in patients with peripheral vascular disease and carotid arterial disease. Now, also keep in mind what they did for that study with rivaroxaban was what worked best wasn't just a low dose once a day dose, but it was actually low dose twice a day, which is very different than how rivaroxaban is otherwise prescribed. So it may end up being what you're trying to do is avoid those peaks and troughs by splitting the dosing out that way. And you may get similar benefits from a low-dose apixaban strategy as well.
Okay. Thank you. Now we go to Dr. Tripodi. Now, kind of a hypothetical question. So do you think hemophilia per se, without proper replacement, decreases the risk of thromboembolism in patients with COVID-19? Like, do our patients with hemophilia, if they get COVID-19, they are at a lower risk? And do you think now them getting replaced with prophylactic, like factor VIII, let's say for hemophilia A, increases that risk?
Yeah, I do not have a personal experience on that, but I read something in the literature, and I think it was a report on a patient with hemophilia who was on prophylaxis with emicizumab, and actually he had COVID-19, but thrombotic problems were really not very important at the moment. So I think this is very important to collect the data from this patient. You may be right. Probably in this patient, the risk of thrombosis could be a bit lower than the normal population, but it's very difficult to see it at the moment. So we have to collect information. But actually, it could be really, I would say, the situation like you mentioned, that given the fact that those patients have some procoagulant effect, even though they are on prophylaxis, for instance, with the emicizumab, probably this may protect this patient from thrombosis, but you have to collect data because I'm not sure about this.
Thank you. Now, the question to Dr. Otel. I mean, two related questions, actually. Which is the DUAC of your choice? I'm kind of political thing.
Okay, so that's an interesting question. I think that for most patients, the DOAC I use most frequently is apixaban. However, for those participants, and I do have a number of people who say they can't seem to remember to take a pill twice a day, but they can do it once a day, I will use rivaroxaban. So I prefer rivaroxaban for the convenience of once a day dosing, but most patients I usually will treat with apixaban because I do like the twice a day dosing given the half-life of the drug.
Thank you. On the related question now, specifically, which of the DUACs has the lower risk of bleeding in cancer-associated thrombosis?
So none of the trials have actually done head-to-head comparisons between the different direct oral anticoagulants. And that's been a significant problem, I think, in trying to address these kinds of questions as far as between the DOACs, which would be safer or more efficacious. I think that the only thing that I would say is that the bleeding, the gastrointestinal bleeding complication rate seems to be a bit higher with dabigatran and with rivaroxaban than with apixaban and edoxaban. So there might be some difference in the type of bleeding across the different direct oral anticoagulants, but I don't think we have enough data to actually try to do a direct comparison between different ones.
And do you believe compared to kind of standard of care, they do increase the risk of bleeding compared to, let's say, low molecular weight heparins?
In the cancer patient population?
In cancer.
I think there, if you just look at the aggregate, I would say no. I do think that we may find that there are certain types of cancers where there might be subtle differences as we continue to treat more patients this way. And there might be some differences, again, with dabigatran and rivaroxaban in certain patient subsets, such as those with gastrointestinal malignancy. There might be more of a problem with those particular ones in that particular setting.
in the burst of those meta-analyses that came after the first RCT, there was a signal, but it was not statistically significant, right?
There was a signal for bleeding, for major bleeding. But then when you looked at like clinically relevant non-major bleeding, that's where you started to see a significant difference. But with major bleeding, it was a trend, but it was not significant. That is correct.
Yeah. One could argue that, trials are powered to detect the primary outcome, not the bleeding outcomes and the safety. So are we confident that they do not increase the risk of bleeding?
Well, I think that for major bleeding, again, I think that when you look at the aggregate number of patients who have been treated over time, really we don't see an increased risk overall in that rate of bleeding, again, unless you start looking at subsets of certain cancer patients. But otherwise, we haven't seen that.
Thank you. Question to Dr. Tripodi. So, when you look at the multiple abnormalities in the coagulation that you see in COVID, which one would be, let's say, in centers where you have limited access to the advanced testing, which one that would be of your choice that we should do it, that would be independent when you put it in a multivariable analysis?
Difficult question to be answered, because I think that we should look at different parameters to have a clear picture of the situation. But if you have to make a choice, I think that for sure, the dimer, I think, would be the favorite assay, simply because it is very sensitive. But as I mentioned, it is very difficult to give it some, I would say, role in the management of patient, at least until data from trials, from prospective trials will come. At the moment, we know that it is a very, very sensitive parameter. So whenever the dimer is going to increase, for instance, if you look at the progression over time of the increasing levels of the dimer, you can define some good information, because it means that your patient is going to have an increased risk for thrombosis, even though the data, as I mentioned, are not prospective but are retrospective. But actually, I think that the dimer would be useful, particularly not the baseline of the dimer maybe, but also the progression in the abnormality of the dimer. Then I put some value also to the, if we wish to know something about the endothelial perturbation, which is very important in these patients. I think that you have at least to measure von Willebrand factor antigen, and even Adams 13, as I mentioned, could be useful. But actually, at the moment, we should collect the data and wait to see whether there are prospective studies which gives a real value in the management of these patients.
A related question on the significance of this Adam TS13 level in predicting mortality. It's not easy to get Adam TS13 for the classical indication. So is it really, does it really predict mortality if you test it, if you put the other clinical parameters in a model that could take out the significance of Adam TS13 in predicting mortality?
Yes, I know. I think that's in the current studies, this has not been, I would say, accurately evaluated, because the sample size was relatively small, and therefore this analysis you are suggesting, multivariate analysis, has not been done actually. I believe that if the number of observation is relatively high, and there is a possibility just to look at your patients and see whether there is one or more factors which can be taken together. For instance, I can imagine a sort of scoring system which includes, for instance, some laboratory parameters and some clinical observation in your patient. And probably, I think that the score system is likely to be valuable in this context, but actually we have to devise first the score system, and then you have to validate the score system in a prospective population. And that, I think, is the crucial problem at the moment, because we only have at the moment retrospective information, which you can imagine in most cases are biased, and it's very difficult to give them some, I would say, value in monitoring patient other than understanding the pathophysiology of hemostatic derangement in COVID-19.
Oh, thank you very much, Dr. Tripodi. Now I see Prof. Pibandi joining again. So, Prof. Pibandi, can you start again? Sorry for the.
No, don't worry. This is a problem with the digitals. I have to say your organization actually is working very well, but this is a problem. Yeah, I was just starting my talk regarding the rare bleeding disorder, and here, just let's go to see the definition of rare bleeding disorder. The rare disorder are affecting 5 people in 10,000 of the general population usually. And this patient seems to be very low as the number. However, they require lots of attention for the multi-domain type of management of this patient, labs and clinician, different specialists that they have to work together. So few number, but lots of attention. However, in your area, I would say this type of patient are not very rare, and the numbers might sometimes be similar to hemophilia B, because of the consanguinity of the population. I think the first action, which is very important to understand whether there is a national database. I remember a few years ago when I came to Saudi Arabia, we had a discussion regarding the organization of a national registry. And recently I saw this paper that it seems there is still some problem with having a proper national registry. And according to the Ministry of Health, I saw that there are about 6,000 to 8,000 type of rare disorder, and 75% of these rare disorders are affecting children, and 30% of patients die before their 5th birthday. And 80% of rare disorder have identifiable genetic origin. And I think it would be extremely important then to really work in management of these patients. Let's go to look on the distribution of every single type of rare disorder regarding the data of World Federation of Hemophilia and our registry in Milan. And usually hemophilia A are affecting 1 case in 5,000 of boys that they are born. And rare disorders can be very, very variable between 1 case in 500,000 for factor 7 up to 1 in 3 million of general population, like factor 2 deficiency or factor 13 deficiency. And the annual global survey based on 115 national registry showed about 324,000 patients were affected with the rare disorder, and about half of them are affected with hemophilia. And recently, we've seen an increased number of rare disorders up to 10%. And that means we are improving in terms of identification and diagnosis of our patients. And if you look on the data, we can see that factor 7 is about 38% of this group, and factor 11 almost more or less similar, followed by factor 10, fibrinogen deficiency, which are 10%. And then we're going to go to more rare cases like factor 5, factor 13, and factor 2. However, as I said, the data that has been published by the group of Tarek showed recently that in Saudi Arabia, the factor 5 deficiency is about 26% of the population. And an additional interesting data is coming to the similarity of factor 8 and factor 9. Here, I think we need to understand whether really these numbers means that hemophilia A and B are similar, or because hemophilia B are less severe compared to hemophilia A, and that's the number of the affected patients are less. And even there, we need to look on the data for factor 7, also factor 5. You can see how different it is from the rest of the world. The type of the clinical manifestation in this patient are extremely variable. You have those patients that are similar to hemophilia and bleeding a lot, and you have those patients that they are bleeding mainly on the mucosal tract, and when there is a big surgery. And that's the time usually you can find the person to be affected with a rare disorder. In that region, also circumcision is one of the problems with the affected boys, and that's the time of the discovery of the rare defect. And for the women, delivery and labors is creating a lot of bleeding event. CNS bleeding is frequent in factor 10 and factor 7 deficiency, and GI bleeding is mainly in factor 10 deficiency patients. And women with afibrinogenemia and factor 13 deficiency could suffer a spontaneous and repeated type of abortion. I want to bring your attention to women with inherited bleeding disorders. The reason why I think these women need more attention, because their trouble is starting from a very early age on their life. When they have their first menstruation with the first menarche, up to every month having a problem of bleeding during the menstruation, and then during the pregnancy and remaining pregnant, and after during the delivery. And sometimes the women with coagulation disorder could have ovarian cyst bleeding, endometriosis, endometrial hyperplasia, polyps, and fibroids. And all this makes extremely difficult the life of these patients. And we have to consider the best marker that you can use is the level of ferritin or iron deficiency, anemia. So what I want to ask you, please, when you have a woman with rare disorder, definitely look for the CBC and ferritin level of these women. Because if they have a very low level of iron and ferritin, they could have very bad quality of life, and that could affect their social life at work, at school, at family, or everything. So I think the doctors, they're working in the area of the Middle East, should pay more attention to that aspect. And when a woman is coming to the observation, even of those physicians that they are not expert, they have to make a good differential diagnosis, because there could be gynecological abnormality, but it could be as well, as we've seen, hemostatic alteration, which needs the screening test for that with a good laboratory testing. But we have to know what type of test to do. And during the pregnancy, we know that fibrinogen, factor 7, 8, 10, and von Willebrand and PIEs, they are increasing. However, in some of the deficiency like factor 2, 5, and 9, there is no increase of the level, and sometimes you can also, for the consumption, having the decrease. So that means the women with this type of deficiency definitely do need to be protected by the infusion of the single concentrate or whatever product is available during the first 3 months of pregnancy and eventually during the delivery. Now, the key question is to understand how to make the diagnosis in those cases that we have the suspicion of the rare disorder, whether there is any association between the phenotype and clinical severity of the patient, and what is the best treatment in terms of acute, and who are those portions of the patient requiring prophylaxis, and what we have to do for the women and the girls. I don't think for this audience, I have to make an explanation of what are the tests that we can use for the diagnosis of the rare disorders, and mainly APTT, PT, and TT are solving the issue for the specific type of deficiency. However, their sensitivity is a matter of issue for the remaining amount of factor, and particularly for the minimum level for prophylaxis of the patients. However, you can have the patients with a factor 13 deficiency, and this type of tests are not enough, and you need to act differently. And the mixing study, of course, is important when you have a prolonged PT and APTT. And as I said, thrombin time is important for the fibrinogen deficiency. And here is the list of all activities that can be measured. There are two factors. A part of activity, you need to have also the amount of the protein by antigen level. And that's in the case of fibrinogen deficiency and prothrombin deficiency, because the presence of positive antigen could lead to the different type of diagnosis. Instead of afibrinogenemia, the patient could have dysfibrinogenemia, or in type 2 could be dysprothrombemia, and that pictures could be associated with a higher number of thromboses, and the type of treatment might differ. So to make a long story short, a part of the assays that I showed, you have to keep in mind that for fibrinogen assay, you need a Klaus assay. And for factor 13, I know that in the region, clot solubility assay is used, but that's not longer recommended and by the ISTH, and also because this assay is poorly standardized and is detecting only those patients with a severe type of deficiency. What about the gene mutation? Once we have identified the patient with a phenotype analysis, you have 3 sets of genes involved and which are encoding the proteins that are involved in rare bleeding disorder. The first are genes that are coding fibrinogen factor 2, 5, 7, 10, 11, and 13. And the second group of patients are factor 5 and 8 deficiency, and the group of David Ginsberg made extremely important data 30 years ago almost, coming with 2 genes, MCFD2 and LMAN, who are responsible for the secretion of factor 5 and 8, so are responsible for the secretion pathway of these 2 proteins. And then you have the third group, which are vitamin K dependent factor deficiency, which are 2, 7, 9, 10 protein C and S. And you need to analyze the genes like GGCX and VKORC1, which encode enzyme who are involved in the post-translational modification and in vitamin K metabolism. How we make the gene analysis? In the last 40 years, we are working from 80s with the PCR and Sanger sequencing, which is a gold standard and is the best methods and simple interpretation of the data. However, if you want to look on more genes that could be involved in such a phenotype, now these days, most of the labs, they're going to the next genetic analysis or next generation sequencing analysis, which is less cost effective, less time consuming, and there is a high throughput method, and also you need much less DNA. But there are some troubles with this type of technology that you might need to have experts, bioinformatic, for understanding what are these variants, and then you need to check these variants with the Sanger sequencing. Recently, there was lots of interesting data coming from public databases containing huge genomic data, and that type of information was very important for data mining and trying to increase the number of the gene mutation for every single coagulation factor. For example, our collaborative studies with Dr. Stefano Duga and Roxana Celta just came over recently with factor 11 and factor 5 deficiency, where they doubled the number of the gene mutation in these two genes. When we study the genetic mutation in the patient with rare disorder, we end up always with 5 to 10% without any gene mutation. And of course, in those groups, genome and exome analysis are very important. And is also very important, this type of analysis, in the group of the patients where the phenotype is not really matched with the genotype. And you want to understand, for example, what is the correlation between the genotype and phenotype? Because we know that null mutation and large deletion and insertion are responsible for no presence of protein. However, the missense mutation could be very heterogeneous, and the phenotype could not be completely explained. And that's the reason you need really, by the next gene analysis, to understand more groups of the gene that interact together for the specific type of phenotype. Now, let's move about when we have the gene mutation, how is the correlation with the phenotype? To understanding that, we try to look the data on the mice models, and you can see for fibrinogen, factor 5 and 8, 11 and 13, the completely knockout mouse were compatible with the survivor in the adulthood and non-embryonic lethality. And not always this picture is also confirmed in the humans. And to understand better the amount of the factors that is necessary for the patients, we went through 3 years data collection system in Europe, 13 countries, and almost 500 patients. And we established a standardized way of clinical severity description, asymptomatic, grade 1, with minor bleed after trauma or drug ingestion, grade 2, spontaneous minor bleeding by bruising and ecchymosis, and other type of mucosal bleeding, and grade 3 with severe bleeding like CNS and GI bleeding. And here you can see there were 3 classes of deficiency, those excellent, like fibrinogen factor 10 and 13, where there was excellent correlation, no factor, and very severe clinical condition. For factor 5 and 7, there was not always like that, and correlation was weaker. And for factor 11, there was no correlation at all. And that's the reason why for factor 11, we need to understand a little bit more in the future. And there are further data that I don't have time to go through, but it seems also that fibrinolytic activity is different in factor 11 patients. And once all of this has been done, you do need to treat this patient. And that is the most difficult part, because in the last 20 years, there was lots of new product for hemophilia and not so much for rare disorders. First of all, you have to understand whatever product is available in your country is better to use the single factor concentrate. Secondly, make sure that is free of the virus infection, hepatitis C, hepatitis B, HIV, or any other type of contamination. And then we can go with the PCC and the last with the cryo and FFP if we do not have any other choices, but we have to make sure that are virus inactivated. Non-transfusional treatment like antifibrinolytic, fibrin glue, hormones, and desmopressin is very valuable type of product that can be used for especially mucosal type of bleeding. On-demand treatment could be very different from patients to patient because of the half-life of patients. Because of half-life of products. And prophylaxis is even more difficult. For prophylaxis, you do need to understand which portion of your patients really have severe type of clinical manifestation, and that are about 10%. Please do not wait for the cerebral bleeding to start the prophylaxis. try to understand if in a family there is a severe bleeding. And in some of the deficiency, like factor 7, the prophylaxis is very difficult because you have to do it at least once a day or 2-3 times a week. For factor 13 is enough to make it only one every month. And that really changed the quality of life of the women, for example, for prevention of recurrent abortion. So this table is lots of information, but what I want to invite you, identify the patient, keep the levels around 20-30%, and make sure mainly that the product is safe. And don't forget about your women. Start with the hormonal therapy. Of course, if the woman is at the reproductive age, you cannot go with the surgery, endometrial ablation, or hysterectomy. Pay attention to that. Try to support these women with hormonal therapy and eventually with a substitutive therapy for few days a month when they want to keep the reproduction. Age of the woman, overall the health, medical history, and the cause and extent of menorrhagia, and also the tolerance for a specific medication and procedure and therapy is important. And don't forget the effect of menorrhagia and anemia in the style of life of your patient. And you know very well that in that region of the world, lots of women could have a problem of divorce and the problem of legal issue, and we need really to protect them. And we have to talk with all these women to understand their culture, their personal choice, and go for the best treatment for them. And with this one, I think I finished my presentation just to report that you need to make the protection of your women even during the pregnancy and during the childbirth, and trying in women with factor 13 deficiency and fibrinogenemia to protect them in the first 3 months. And at the end, novel therapeutic strategy like extended half-life products, anti-TFPI, emicizumab, small interference RNA, all these have been tested in hemophilia. And I think there are really good products for the future in rare bleeding disorder. And we need to make sure that the companies get interested in the rare disorder and maybe even the gene therapy, and try to make sure that you are creating your global or national partnership with the collection of the data, making better assays, and trying to bring the attention of the public health. And also, we need really understand better this group of heterogeneous rare bleeding disorder. And with this one, I want to thank you and also thank all those people that are listening to this presentation who collaborated with me in the last 30 years for the collection of the data that I have shown.
Thank you, Dr. Pravandi. Very informative presentation. And again, apologies for this technical problem. Because of time, I'll limit the questions to maybe 1 and 2. The other 2 speakers, we already finished their questions. Although I have actually more, but because of the time, we cannot ask them. So the 2 questions to you. In a lab with like basic hemostatic, not basic, but not very advanced research lab, how would you differentiate between quantitative and qualitative disorders of the fibrinogen, dysfibrinogenias or hypoafibrinogenemias?
Very good point. Actually, for this fibrinogenemia, you need to have the antigen level. And without the antigen level, you won't be able. I mean, you want to make sure with the clause that the activity is not there. But once you find out the activity is not there, you want to make sure that the level of antigen is not normal. Because then, for the infusion of the concentrate is a problem. Because if you make a wrong decision, you might bring arterial and venous thrombosis in a patient with dysfibrinogenemia, where the bleeding is much less.
Okay. Thank you. My other question is, when you do mutation analysis using like a more advanced NGS technology, I mean, you said when we do the PCR Sanger sequencing, we don't get a positive mutation in a clearly a patient with the bleeding disorder. However, when you do NGS, the common problem is that you get many unknown variants. I mean, in bleeding disorders and in other disorders that you cannot interpret well whether this is associated or related to the bleeding disorder.
That's a very good point. That's exactly what I wanted to say. Thanks for bringing that out. I think in Europe, this is a big issue because we don't have the big families with lots of generation, because the best thing would be to have more than 2-3 generations and more people suffering from the same type of clinical symptom. Even few families like that, or even one single family like that, can help you with the next gene to find out what are the genes that cause the disease. Now, if you're working on the single gene alterated disease, one very well organized family could be enough. But if you're working in a common disorder, when the penetrance of each single gene is not very high, then the trouble is there. Then one family is not enough. You need really huge numbers because the power of your study is much smaller and the role of each single gene is a little. So that's the reason why it makes more difficult. But for rare bleeding disorders, if there is a good phenotype and good phenotype lab and clinical evaluation, next gene would be helpful, I think. You need a good bioinformatician, of course, to clean up.
But you need more than one generation, right? Or...
Absolutely more than one generation.
So you cannot do it without siblings and parents?
You can make it in one single, I mean, you can do that, but your power is much less. You can do it more people on the same generation, but the power is really less, and you might end up with nothing.
Okay. Thank you very much.
You're welcome.
I guess we're coming towards the end of this session. Very interesting, very useful session. I would like to thank the speakers, Prof. Ortel, Prof. Taipodi, and Prof. Privandi for their excellent talks. I would like to thank the organizers. And I also would like to thank the 4,612 attendees. Very good number. That is a reflection of the interest in benign hematology and in the session itself. So now we
like Ash. You're becoming the second Ash.
So we would like to invite the audience and other attendees to go to the exhibitor tour. It would be virtual. I promise you that you would see a lot of interesting and useful material. So please spend some time going there. And I guess because of the time issue, the break would be only 5 minutes. And with that, I would like to again thank the organizer for inviting me to moderate this session. Thank you very much.
Thank you very much. Ciao Armando. Bye Thomas.
Thank you. Bye, Flora. Bye, Armando.
Bye.
So back at 9:30, please. Thank you.
And thank you all for joining us tonight. We're very pleased to be able to welcome you again in joining this event. And today is, as you know, the 7th day of the Congress. And this is the final day of the Congress. And we hope that all the knowledge and, science that was shared by our prominent and distinguished speakers can be applied to our daily practice for the better care of our patients. I don't want to take much of your time, but if you allow me, I would just share with you one slide about King Faisal Specialist Hospital Research Center hematology section with regards to landmark activities and milestones in the history of hematology care at King Faisal Hospital. If you see in this slide, we had the bone marrow transplant units established in 1980s. We had the first allo transplant in 1984, and allo in the the auto is in 1985. There are many other landmark historical achievements that you can see here. One of them is we were in 2010 one of the first BMT centers outside Europe to be JCA accredited. We had also been ranked as the #1 worldwide for BMT in sickle cell disease and inherited bone marrow failure, and top 2% of BMT centers worldwide between 2016 and 2019. We had our first CAR T-cell therapy infused in December, and we have now we are contributing in 2 clinical trials in gene therapy and hemophilia. We have a very active alternate donor program with matched donated donor registry, from which we have transplanted around 80 patients, and nationally and internationally. So this is about some of the section's landmark achievements. And we go back to the conference. We have very interesting session tonight on the issue of, along the theme of thrombosis and hemostasis. We have 2 distinguished speakers. We have Professor Mark Crowther speaking first, and then we have our other colleague, Professor Paul Copo. So we'll start with the first session on practical aspects of reversal of direct oral anticoagulants. This session will kindly be presented by our distinguished speaker, Dr. Mark Crowther, who is currently the chair of the Department of Medicine at McMaster University and holds the Leo Pharma chair in thromboembolism research at McMaster University. Dr. Crowther's research interest includes exploring ways of improving the way that our current anticoagulant drugs are being best delivered for the safest, with the safest outcome for our patients. So, starting with Professor Crowther on the practical aspects of reversal of oral anticoagulant drugs.
Or afternoon, everyone, and welcome to my presentation. I'm Mark Crowther. I'm the chair of the Department of Medicine at McMaster University, and I'm going to talk today about the 2021 approach to anticoagulant reversal. I'm using my own slides plus slides from a variety of other people, most notably Dr. Adam Suker, who's a professor at the University of Pennsylvania and a good friend of mine. I have a number of disclosures. I won't go through these in detail other than to say that over the years, I've done work for all of the companies that make anticoagulants and all of the companies that make reversal agents. I also hold an endowed chair at McMaster University, which is funded to allow me to continue to do my research activities. With respect to reversal, the direct oral anticoagulants have almost completely replaced warfarin except for some specific unusual circumstances. But warfarin use remains highly prevalent in what I call the chronic user population, people who've been on warfarin warfarin for years and have no intention of switching. The direct oral anticoagulants were introduced in the absence of specific reversal agents, and for the most part, such agents are simply not required. So the question is warfarin dead yet? And this is relevant to reversal because the most common kind of reversal that we do in our hospital at McMaster University is not DOAC reversal, it's actually warfarin reversal. In fact, warfarin reversal probably outnumbers DOAC reversal by at least 10 to 1. The short answer about whether warfarin is dead yet is no. Warfarin remains the most commonly prescribed anticoagulant because there are many patients out there who've been taking it for years. It also is the least expensive of the agents. And it is going to be the only agent that's going to be preferred for a number of clinical settings, including mechanical heart valves, patients with renal insufficiency, patients with more significant forms of antiphospholipid antibody syndrome, and also because of physician inertia. That is, physicians are going to continue to prescribe the drugs they're most familiar with, which in this case is going to be warfarin. In terms of reversing warfarin, because any reversal talk wouldn't be complete without covering this off, the most important drug, in fact, the only drug that should be considered for the reversal of PCC is, for the reversal of warfarin, is prothrombin complex concentrate. Remember that warfarin has two highly effective antidotes, prothrombin complex concentrate and vitamin K. Both should be administered together in patients with major bleeding in the setting of warfarin anticoagulation. Prothrombin complex concentrate is rapidly acting virally inactivated, small volumes of plasma, rapid infusion, and no cross match is required. And vitamin K, when given intravenously, is inexpensive, widely available, but does not act in any way in a quick fashion. So when reversing warfarin, guideline recommendations from all major peer organizations, such as the American College of Cardiology and the American Society of Hematology, recommend the use of PCCs over fresh frozen plasma. And there are other agencies that also recommend this. The National Advisory Committee in Canada, which guides the use of blood products, has also come out with a recommendation to use prothrombin complex concentrates for warfarin reversal. And they say that the prothrombin complex concentrates are indicated for rapid reversal of warfarin therapy or vitamin K deficiency in patients exhibiting major bleeding manifestations, and for rapid reversal of warfarin therapy or vitamin K deficiency in patients requiring urgent surgical procedures. So there should be no complexity to how major bleeding in a warfarinized patient is treated, irrespective of the INR. It should be with the administration of PCC plus vitamin K. There's nothing more to say about warfarin reversal, I don't think. Remember that if a patient presents with a high INR without bleeding, you don't need to reverse them. You can withhold doses of warfarin and allow the INR to coast down before restarting. If the patient is perceived to be at moderate risk of bleeding, then you might consider giving a low dose of vitamin K to reduce the risk of the INR remaining persistently elevated. And if the person is perceived to be at high risk of bleeding or is active bleeding with warfarin, give them PCC and vitamin K. So now let's move on to the direct oral anticoagulants, which is the focus of the talk. Mrs. Smith is a 72-year-old woman with atrial fibrillation and a CHADS-2 score of 4, which puts her at high risk. Her primary care physician starts her on dabigatran at a dose of 150 milligrams twice daily for stroke prevention in the setting of her high-risk atrial fibrillation, and fails to notice that she has a creatinine clearance of 23 mils per minute. That is obviously a contraindication to the use of dabigatran. Renal insufficiency and dabigatran just don't mix. Dabigatran is very dependent on the kidneys for its clearance. 2 weeks later, she presents with major hematemesis to the emergency department, to no one's surprise. One of the questions we get asked when we're approaching a person who may need reversal is, how do you tell if they have a direct oral anticoagulant on board? And for dabigatran, it's actually relatively straightforward. Dabigatran, when it's present in significant amounts, will increase the PTT. So this patient we're talking about right now, we would expect her to have an elevated PTT. In addition, even small amounts of dabigatran will increase the thrombin clotting time, the eccrine clotting time, and a specific assay for dabigatran, which is known as the hemoclot assay. You can do specific levels of dabigatran using the hemoclot assay, but those are only going to be available in selected centers and usually only during office hours. If the patient's taking rivaroxaban, apixaban, or edoxaban, things are a little bit more complicated. For rivaroxaban, if the INR and PTT are usually normal, or the PTT is normal and the INR is slightly prolonged, you cannot use the INR for monitoring rivaroxaban. So if a patient shows up in the emergency department and the question is, do they have rivaroxaban on board, and their INR is 1.8 and they have no reason to have an INR of 1.8, you can safely assume that they've got rivaroxaban on board. Apixaban does not reliably prolong any clotting test. So you could take a large dose of apixaban, and 3 hours later, when you're at peak pharmacokinetic effect, you would not expect the person to have any significant prolongation of their INR. There are specific assays for both rivaroxaban and apixaban that are very sensitive, and there's a couple of different technologies for this. But again, these are only going to be available in selected laboratories and only going to be available during usual office hours in the vast majority of cases. Edoxaban behaves somewhat like rivaroxaban, so it should prolong the standard clotting test when it's present in high amounts. So with respect to this patient, remember, older lady, dabigatran, severe renal insufficiency. The question is, what lab test would be most helpful to determine if she has dabigatran on board? The INR, the PTT, thrombin clotting time, ROTEM, or the platelet count? There's really two answers to this. The TCT is the most sensitive. The problem with the TCT is that even if you have a small amount of dabigatran, it's going to become incoagulable. So if the TCT is abnormal, that means she has dabigatran on board. The PTT is actually a little bit quantitative. So the higher the PTT, the more dabigatran on board. And so for this one, I've said the answer is the PTT. Assuming that testing returns promptly, the PTT is found to be 135 seconds with a normal time of less than 35 seconds. The question is, if it's available, should she receive idarucizumab, yes or no? So this woman presents with a major bleed in the setting of a direct oral anticoagulant. What is her risk of death? Risk of death is really high, and I'll show you some evidence to this effect in a minute. And so she should receive idarucizumab if you have it available. Another question we get asked all the time is, once you've infused the idarucizumab, how quickly will the anticoagulant effect of the dabigatran be eliminated? Less than a minute, less than 5 minutes, less than 30 minutes, less than 1 hour, or it will not be eliminated? The answer is immediate. The drug immediately is bound to the idarucizumab and cleared from the circulation, so it provides immediate reversal. Direct oral anticoagulants and the other anticoagulants are high-risk drugs, and so this is data published by Dr. Nadine Shahab, looking at U.S. emergency department visits for outpatient adverse events in 2013 and 2014, and this looked at the drugs that were most likely to cause emergency department visits. And you can see that in this list, of the top 5 drugs, 4 were antithrombotic agents. Warfarin dominated, followed by insulin, then clopidogrel, aspirin, and rivaroxaban. And if you repeated this now in 2021, you would probably find that apixaban is on this list. So the anticoagulants are high-risk drugs. They have a high rate of complications, and they frequently cause complications such as bleeding, which require hospital visits and hospital admissions. So whenever a person is on an anticoagulant, remember that they are high-risk drugs, use them in compliance with guidelines, and when bleeding occurs, it needs to be managed aggressively to prevent the patients from having an adverse outcome. A question that we get asked all the time about, particularly rivaroxaban and apixaban, is, do we need a reversal agent at all? These drugs are highly safe. Bleeding is uncommon in patients anticoagulated with the direct oral anticoagulants. Bleeding is not actually caused by the drug. It's caused by compromised vascular integrity. That is, there is a hole in the blood vessel which is bleeding. The drug itself does not cause the hole in the blood vessel. Bleeding risk factors can be identified and mitigated. You can reduce the risk of the person suffering bleeding. Reversal strategies are ancillary to fixing the lesion. What I mean by that is that the primary way you deal with bleeding is to have an interventionalist go and identify where the bleeding is coming from and fix that. All bleeding stops. You can be confident that bleeding is going to stop. You just want to make sure that it stops physiologically or as a result of your therapies, not because the patient has died. So all of these things argue that you don't need a reversal agent because most bleeding is going to stop, and most bleeding is fixable with interventionalists. However, there are some reasons to have a direct antidote. One is that the simple availability of an antidote is going to increase physician comfort with using the drugs and increase their appropriate utilization. And a patient who's actively bleeding, reversal agents may reduce the severity of the drug, and reversal agents may reduce the likelihood of bleeding if used prior to selected interventional procedures. So just talking about that for a second, because a very common cause of bleeding is perioperative bleeding. In fact, in my hospital, I was on call last weekend, and we had a patient who went to the operating room, and the surgeons had failed to notice the patient was on warfarin and immediately prior to the surgery had an INR of 2.2. Obviously, that's a completely avoidable cause of bleeding, but it is an important cause of bleeding, inadvertent procedures, or procedures done because they were emergent in a patient who's anticoagulated. For elective surgery, careful management of anticoagulants to minimize anticoagulation risk at the time of surgery, while also ensuring the lowest possible risk of thrombosis, will mitigate the risk of bleeding and mitigate the need for reversal agents. And there's a whole separate talk to be had on bridging strategies. And for urgent and emergent surgery, you need to have meticulous attention to surgical technique and consideration of the use of reversal agents. Accurate and timely laboratory testing is also critical to prevention and management of bleeding, because it provides, in some cases, an estimate of the degree to which anticoagulant is contributing to bleeding, and will also guide the use of reversal agents if testing is available in real time. And I know, for example, at King Faisal in Riyadh, you have access to really excellent laboratory testing, but I know that in many other centers in Canada and in Saudi Arabia, particularly quantitative level drugs are just simply not going to be available in a timely fashion. The easiest way to treat a bleed is to avoid having it, and there's a wide variety of excellent, very clear tools available to provide advice on how to optimally use antithrombotic agents in order to reduce the risk of bleeding. And the most common reason why avoidable bleeding occurs is physicians add antithrombotics one on top of the other inappropriately without actually considering why they're using multiple antithrombotics. And there's a wide variety of different evidence-based and free guideline tools on how you should use antithrombotics. I presented two here. The Canadian Cardiovascular Society has a large number of guidance documents, as does other agencies such as the American Society of Hematology and the Thrombosis Canada. And these guidelines will help you to practice in compliance with the recommendations, and by reducing and rationalizing your use of anticoagulants will minimize the risk of you causing avoidable bleeding. A good example of this is a study published recently by Dr. Renato Lopes, who works at both Duke and in Sao Paulo, Brazil, which was looking at the optimal antithrombotic therapy after acute coronary syndromes, or PCI. And so this is the question of, if a person has atrial fibrillation and also gets a stent put in, should they be put on triple therapy? And we now have clear data to inform us about how these people should be treated. If you have a patient who has atrial fibrillation and has an acute coronary syndrome, or PCI, the combination of apixaban plus clopidogrel is safer and more effective than any other combination involving warfarin or triple therapy. Apixaban plus clopidogrel causes similar or lower risks of bleeding and similar or better efficacy than anything else. And so if you ever see a patient who's on warfarin and aspirin and clopidogrel in 2021, that is placing the patient at unnecessary risk of bleeding, and you should use the results of the Augustus study plus others to inform your practice and to get the person off the aspirin and put them on a more rational treatment strategy. Not only will this result in them having a better clinical outcome in terms of their coronary syndrome, but it will also reduce their risk of otherwise avoidable bleeding and reduce your need to reverse them. Implementation of these evidence-based guidelines will dramatically reduce warfarin-associated bleeds and reduce the need for reversal strategies. And the easiest way to treat a bleed is to not have it in the first place. What is the consequences of major bleeding? Well, these are significant and severe. This is a paper published by a colleague of mine, Dr. Chayat Saksofa, who is from Thailand. It was published in Blood in 2014. And what Chatri did is he took all of the studies that led to licensure of the direct oral anticoagulants. At that time, there were 102,000 patients enrolled in these studies. And what Chatri was able to show was that when you compared therapeutic dose direct oral anticoagulants with therapeutic dose warfarin, major bleeding was reduced by about 28%. Fatal bleeding was reduced by almost 50%. Intracranial bleeding was reduced by almost 60%. The only bleeding that wasn't significantly changed was GI bleeding. And so using a direct oral anticoagulant when compared to warfarin resulted in really important reductions in intracranial and other forms of bleeding. And so another way to reduce bleeding is to switch patients who are able to be switched from warfarin to a direct oral anticoagulant. By doing that, you will reduce the need to reverse people because the rate of bleeding will be reduced. So the question is, if you have a patient who's on a direct oral anticoagulant and is actively bleeding, when do you actually intervene to reverse that patient? And there is some evidence to help us to understand when this should happen. You should ask yourself, in my opinion, 3 questions. The first question is the drug present in significant quantities? And remember that if the patient presents to the emergency department in the study that we did that led to the licensure of andexanet, almost 25% of patients didn't have important amounts of the drug present. So just because the patient comes in with a pill bottle containing rivaroxaban, they may not have it on board. It's really important to try to determine when they took their last dose. If the person took their last dose of rivaroxaban 36 hours ago, then it's very unlikely that they're going to have drug present. The second question is, does the agent need to be reversed? Clinically important or clinically impressive bleeding doesn't always require reversal. So epistaxis, for example, may look spectacular, but it does not need to be reversed in most cases. Remember that whenever you reverse a person, you're increasing the risk of otherwise avoidable thrombosis. So if bleeding is minor or easily delayed, or if it's a surgical procedure and it can be delayed, just wait. And you will find that the anticoagulant effect goes away and the bleeding may actually be mitigated by that. In fact, around the world where andexanet is only available in very limited circumstances, almost all DOAC bleeds are currently managed without a reversal agent. If you've decided the drug is present, that the person should be reversed, then the third question is how you do it. Well, there are principles of bleeding management, and there's a wide variety of guidelines that speak to this. Transfuse patients as required, work with your interventional radiology, gastroenterology, or surgical colleagues. Consider the administration of DDAVP, tranexamic acid, or epsilon aminocaproic acid. If the person is on a 10A inhibitor and you have access to andexanet, then you should consider using it. In Canada, we don't have andexanet, so in the setting of life-threatening bleeding, we would use PCCs. If in the setting of life-threatening bleeding with dabigatran, consider idarucizumab. In Canada, we do have idarucizumab and we would use it. And as I presented at the start, for warfarin, use the combination of PCC plus vitamin K. Are there specific implementation strategies that would allow you to mitigate the effects of bleeding? Absolutely. This is a paper published by Adam Suker a couple of years ago. And if you're thinking about how to set up a reversal strategy, I would suggest that you have a look at it. It talks very comprehensively about how to set up a reversal strategy and how to implement it. The most effective way to ensure safe and effective prevention and treatment of bleeding is rigorously adhered to institutional policies. Clinicians who encounter perioperative management and reversal infrequently just can't know how to do it. And so your institutional policies are what are going to lead to effective reversal strategies. If we talk about evidence briefly, there are never going to be large randomized controlled trials of reversal strategies for bleeding because the studies are extraordinarily difficult to do. And we won't get into that today, but you have to trust me on this. Idarucizumab, I'm not going to go into this in great detail. I think you've probably all seen these slides before. Charles Pollock published this paper in 2017, which looked at the efficacy of dabigatran. It's a monoclonal antibody fragment, which comes in pre-diluted vials. It's very easy to use, and it immediately reverses the anticoagulant effect of dabigatran. This is data from the study which Dr. Pollock published. If you have a patient who gets dabigatran and is given a placebo infusion, this happens to their dabigatran level, and as you give increasing doses of idarucizumab, their dabigatran is immediately and completely neutralized for the entire period of the study. So it's an instantaneous and complete reversal agent. In the study, there were two groups of patients, patients who were actively bleeding, about 300, and I won't present the results in great detail other than to say that the patients did really very well, and hemostasis was achieved in the large majority of patients. And a second group of patients, about 200, who needed urgent or emergent surgery, who received the drug. And again, I won't go into detail other than to say that the patients did really well. The 203 group A patients who could be evaluable for bleeding outcomes, 2/3 had confirmed stop of bleeding, and the median stop of bleeding was 2.5 hours. And in the group B patients, hemostasis was assessed as normal in 93% of patients. As I mentioned earlier, remember that whenever you reverse an antithrombotic agent, you're going to increase the rate of venous thromboembolism because these patients have thromboembolic predispositions, which is why they're anticoagulated in the first case. And so in this study, 31 of 494 patients had 35 thrombotic events by 90 days. And this is not surprising. This is not because the idarucizumab causes clots. This is because you took patients who are at risk of thrombotic events and took them off their anticoagulants. And as a result, they didn't have the benefit of the anticoagulants and went on to have clotting events. Andexanet is a modified factor 10A. It's had some chemical magic performed to it, which does two things. It continues to be able to bind to the 10A inhibitors with high avidity. The active site has been changed so that it no longer participates in coagulation. The GLA domain has been removed to prevent an anticoagulant effect, so it can't bind to phospholipid surfaces. And as a result of that, it doesn't interact with coagulation. It has no known interaction with any coagulation factors except tissue factor pathway inhibitor, and it does not cause neutralizing antibodies. Deb Siegel published this paper a couple of years ago where she looked at the effect in patients who were dosed steady state healthy volunteers. And I won't go through this in detail, If you give a bolus of Andexanet, you immediately reverse the 10A effect, and then you have a slow return because the Andexanet has a short half-life. If you give a dose, a bolus plus an infusion, you maintain low levels for the entire duration of the infusion for both rivaroxaban and apixaban. And there's 2 different dosing regimens which are recommended for the use of this agent. This is a licensure study, a total of 325 patients who had acute major bleeding, of which 225 were intracranial, and they were evaluated for both their anti-10A level as well as clinical hemostasis. And suffice it to say that a very high proportion of patients had excellent hemostasis, and the large majority of patients had complete reversal of the anti-10A effect. Just remember, once the infusion stopped, the 10A effect will come back. And then Andexanet's been available in the United States now for a couple of years, and the question is, how has it gone? There's a whole series of observational studies published. This is one an experience at a major non-academic center in the United States. 13 patients with intracranial hemorrhage, 11 of whom had follow-up imaging, and stability in the bleed was observed to 90%. 3 patients received it prior to surgical procedures, which is an off-label indication. None had unexpected bleeding. 9 patients received it for reversal of extracranial bleeding, of which 4 were gastrointestinal. No thrombotic events were observed. Remember, these patients should be re-anticoagulated as soon as it's safe to do so. 30-day mortality was 24%. Interestingly, only 2/3 of the patients would have actually gotten into the Andexanet study. So real-world experience with this drug is limited, but is actually looking very positive. A high fraction of patients have a return of normal hemostasis. So where are we in 2021 with respect to reversal agents? So first of all, remember that the best way to treat a bleed is to not have it in the first place. So when you have a patient who is being considered for antithrombotic therapy, always use rational thrombotic therapy, antithrombotic therapy. Always review current guidelines and make sure your work is in compliance with guidelines. Most patients with DOAC-associated bleeding require only generic supportive management. For life-threatening bleeding in a patient who does or is likely to have important amounts of dabigatran on board, idarucizumab should be used if you have available. If you do not have it available, then you could use activated prothrombin complex concentrate, and the decision-making can be aided by the PTT or thrombin time. For life-threatening bleeding in a patient who does or is likely to have important amounts of 10A inhibitor on board, consider Andexanet if it's available, and if it's not available, consider the use of PCCs. Decisions about the use of very expensive reversal drugs, including idarucizumab and PCC, would be greatly aided by point-of-care testing that is inexpensive, reliable, fast, and truly point-of-care. These tests do not exist in North America, but there is a urine dipstick for DOACs that has become available in Europe that I think actually has a great deal of utility here, and it would be interesting to see whether or not it could achieve approval in Saudi Arabia. Thank you for your attention. I'd like to thank the organizers for inviting me to speak.
Okay. Yes, good.
Thank you very much, Prof. Crowther, for this very elegant presentation on reversal of anticoagulation. I think we'll have questions at the end of this session. So it's now my great pleasure to introduce our next speaker, who is Professor Paul Copo, and he will kindly present to us on the management of acquired thrombocytopenic purpura. Professor Copo is a professor of hematology in Sorbonne University in Paris. He leads the French Reference Center for Thrombotic Microangiopathies and the Department of Lymphoid Malignancies in Saint Anthony Hospital in Paris. His research work is focused on genetics, risk factors, and immune modulatory treatments of immune to TTP. Prof. Copo, kindly please start the presentation. You are muted, Prof. Coco. Can you unmute yourself, Prof. Coco?
Okay, so it should work now. Sorry. So
Yes,
thanks a
we
lot,
can hear you now.
Professor Al-Zarani, for your nice introduction. So I will put my presentation on full screen now. So I hope you can all see my presentation. So I'm very pleased to be here this evening with you to share with you the French experience in the diagnosis and management of thrombotic thrombocytopenic purpura in 2021. So as a reminder here, as you know, TTP is a specific form of thrombotic microangiopathy characterized by the association of a microangiopathic hemolytic anemia, a profound peripheral thrombocytopenia, organ failure of variable severity, and in this disease, we have a biomarker, which is a severe deficiency in ADAMTS13, which is the enzyme that regulates the size of the von Willebrand factor multimer. And this ADAMTS13 deficiency may be either due to biallelic mutations of the encoding gene, or alternatively to autoantibodies directed against the enzyme. So you can see that for both forms of the disease, the incidence of these patients is rare. We are typically in the field of rare diseases, and the incidence of TTP, again, does not exceed some cases per million inhabitants per year. So this is what you need to have in mind regarding clinical presentation of TTP. Those patients are mostly females in 3/4 of cases. There is an overrepresentation of African people and people from the West Indies. Patients are typically 40 years old, and they have cerebral involvement in up to 50% of cases. You can see, interestingly, that on a series of patients published 20 years ago, the incidence of cerebral involvement was up to 90% of cases. But year after year, we learned to make the diagnosis of TTP earlier and earlier in these patients. So now we can diagnose TTP in patients when they only have hematologic features without organ failure. And this is, of course, better for the patients. So this means that we are more and more aware about this disease and the clinical features of the disease. Regarding biology, patients typically have profound cytopenias, especially thrombocytopenia. In these patients, platelet count is typically below 30,000. On the opposite, renal involvement, although quite frequent, is usually mild, with creatinine levels typically below 200 micromole per liter. So these clinical features are very important to keep in mind, because they could be used to derive clinical scores aimed at anticipating ADAMTS13 activity. And this is a crucial aspect in the field, because, as you know, there is some turnaround time for ADAMTS13 activity to be available. And in most centers in the world, ADAMTS13 activity is available after only 3 to 5 days. And even in some centers, the enzyme activity is not available at all. So it is crucial, at the time we have more and more targeted therapies, to be able to make rapidly the diagnosis of TTP and to have an idea about ADAMTS13 activity. And for this, 2 scores were derived from standard clinical features. So I summarized both scores here, the French score and the plasmic score. And what you need to understand is that both scores go in the same way. They state that in patients with features of thrombotic microangiopathy, with no associated condition, including cancer, transplantation, chemotherapy, and severe sepsis, in those patients, a severe thrombocytopenia as defined by a platelet count below 30,000 and a mild renal involvement as defined by a serum creatinine level below 2.26 milligram per deciliter, those patients are almost systematically associated with a severe ADAM13 deficiency. So these two scores are now routinely used for the diagnosis of TTP. The French score has been used on two randomized clinical trials that evaluated the usefulness of caplacizumab in this disease. So those scores proved that they are really able for the management of patients in real world. So this is what you have to understand to understand the treatment of TTP. In these patients, you have in the acquired form of the disease antibodies that are directed against ADAM13, and as a result, the enzyme activity is completely abrogated, and the substrate of ADAM13, von Willebrand factor, accumulates upstream. The high molecular weight VWF multimers are hyperadhesive towards platelets, and this leads to the formation of microthrombi in most organs in microvasculature, and then to organ damage and death in the absence of adaptive treatment. So once you understood that, you can understand easily that in this disease, you need to replenish ADAM13 levels to saturate the anti-ADAM13 antibodies, and then to cleave the large VWF multimers. And this can be achieved by bringing to patients very large volumes of plasma through plasma exchange. The second approach is immunomodulation to block the formation of antibodies against ADAM13. And this can be achieved with immunotherapies, which can be more or less specific. So I can use rituximab to specifically target B cells, cyclosporine to target T cells. More recently, attempts has been made to directly target plasma cells with bortezomib. And historically, other immunosuppressors have been used, such as steroids, as well as cyclophosphamide. And the third and most recent strategy is to inhibit the pathologic interaction between VWF and platelets. And this has been achieved with the use of caplacizumab, which is an antibody able to recognize the A1 domain of VWF and prevent the excessive interaction between VWF and platelets. So this is the historical treatment of autoimmune TTP. The standard treatment consists in daily plasma exchange in association with steroids in emergency until remission. This has been for years the core treatment of TTP. And with this regimen, the prognosis of the disease has been outstandingly improved, since with this regimen, remission and survival is currently of more than 85%, whereas before the systematic use of this regimen, almost all patients died from the disease. So this regimen has been a cornerstone in the management of the disease. However, some unmet needs were still present despite the use of this regimen. First, patients could experience exacerbations of the disease despite daily plasma exchange. And this is a frequent event since it occurs in up to 50% of patients. You can see that in those patients, despite an adaptive treatment, you can observe, for still unclear reasons, a drop in platelet count after an initial improvement of the patient's condition. And this can occur many times in a patient, and this translates in a prolonged time of treatment. So the other unfavorable outcome with the standard treatment is refractoriness. In those patients, despite an adaptive treatment, you cannot see any response to treatment, and patients may remain many days and sometimes some weeks with a severe thrombocytopenia. And this condition involves up to 10% of patients. So those two conditions, exacerbations and refractoriness, which are called suboptimal responses to standard treatment, expose patients to a higher risk of death and to complications of the treatment. And at the time that TTP was becoming a disease of better prognosis, it was mandatory to improve, to still more improve the prognosis of disease and to address those caveats. So for that, we started to use rituximab in this disease, and rituximab clearly, in association with the standard treatment, allowed to limit the duration of plasma exchange treatment in those patients. So we started to observe that the long-term responders were less and less common in the end. And with the use of rituximab, we clearly could limit the duration of plasma exchange treatment. However, the bad news with the use of rituximab is that it is not efficient in real time. And this is a concern because in this disease, we need compounds that are efficient immediately, of course. With the use of rituximab, once you started the course of rituximab, you have to wait for 2 weeks before platelets recover durably. So during this 2 weeks window, patients can still worsen their disease and even die. So there was a need to find a compound able to protect patients until rituximab is efficient. The other very interesting point that was observed with the use of rituximab is that rituximab is able to protect patients from early relapses. So you can see here on this trial driven by the UK group that patients who received rituximab frontline immediately after the diagnosis of TTP, after they recovered from the TTP episode, you can see that these patients were remarkably protected from relapses for 12 to 18 months. On the opposite, patients who did not receive rituximab in association with plasma exchange relapsed quite rapidly after an initial recovery of the disease. So for this reason, as rituximab remarkably protects patients from a relapse, there is a strong recommendation now to propose to these patients systematically rituximab in association to plasma exchange and steroids as soon as the diagnosis of TTP is made. So the third chapter of the management of TTP is the use of carfilzomib. So again, carfilzomib is the first nanobody that could be used routinely in clinical practice. And this nanobody is able to recognize the A1 domain of VWF and to prevent the interaction between the A1 domain of VWF and the GP1B receptor on platelets. So carfilzomib has been evaluated on 2 international randomized controlled trials the Titan and the Hercules trials. You can see here the flowchart of the Hercules trial that randomized 145 patients with either placebo or capacizumab in association for both arms with the standard treatment and for most patients rituximab. So the primary endpoint of the study, of both studies, was the time to first platelet count recovery. So you can see here the integrated analysis of Titan and Hercules, and you can see that for patients who received capacizumab, for those patients, platelet count recovered faster than those patients who received the placebo. And this is an interesting result because this means that patients received the placebo capacizumab remained thrombocytopenic for a shorter time. And this is important because those patients die from the disease during this period of thrombocytopenia. So less exposure to thrombocytopenia means less exposure to death. More interestingly, this positive aspect of capacizumab was specifically observed during the very early time of the management. The difference between the two curves was really clear during the first 2 weeks of the management. And this is interesting because if you remember, this is the window during which rituximab is still not efficient. So one could see capacizumab as a compound able to protect patients with TTP until rituximab improves ADAM13 activity. So clearly, capacizumab and rituximab are two complementary compounds that improve the prognosis of TTP. So these are the secondary outcomes of the studies. You can see very interestingly that the fact that patients recover platelet count earlier translates in less deaths. You can see that in the capacizumab arms, no death was observed versus 4 deaths in the placebo groups. More strikingly, exacerbations were only observed in less than 6% of patients in the capacizumab arms versus 35% in the placebo arms. So this is a very important difference. And at the bottom of the slide, you can see that no patient experienced refractoriness in the capacizumab arms versus 7 cases of refractoriness in the placebo arms. So on the basis of these results, capacizumab obtained a label to be used in autoimmune TTP frontline as soon as the clinical diagnosis is made. So France was one of the first countries to allow the use of capacizumab in such a condition. And we could benefit from an early access program in France. So during this period of time, we set up a regimen that we called the Caplavie regimen to address the usefulness and the tolerance of capacizumab in these patients in a real-world condition. So this regimen is derived from the Hercules trial. And in this trial, we treated patients as soon as they had a clinical diagnosis based on our clinical score, the French score. So for those patients with a French score of 2, which means a severe thrombocytopenia and a mild renal involvement, those patients were treated frontline with daily plasma exchange, immunosuppression with rituximab and steroids, and capacizumab daily. As soon as platelets recovered, we stopped plasma exchange and we continued capacizumab until ADAM13 activity recovery. This is to show the clinical features of these patients on diagnosis. Those patients had typical features of TTP. And during the period of this study that ran for 18 months, we could analyze 90 patients that were treated with this triplet regimen. And we compared the outcome of these patients to our historical cohorts of patients, and we set up this cohort that included 180 historical patients recruited from 2015 to 18. And as you can see in this table, those patients were strictly comparable on diagnosis. Biologically, we had also features that were comparable between both groups. And you have here the detail of the treatment to show that virtually all patients had steroids, and all patients in the triplet regimen had rituximab versus 68% of patients in the historical cohort, because historically we use rituximab as a salvage therapy instead of frontline as we do now. Our primary outcome was a clinical outcome. It was a composite of death and refractoriness. And you can see that only 2 patients out of 90 reached this outcome in the triplet regimen versus 22 patients, 12%, in the historical cohort with a statistically significant difference. Interestingly, the favorable outcome of patients in the triplet regimen was irrespective of the severity of patients on diagnosis. So this means that the triplet regimen could circumvent the bad prognosis of the historical prognosis factors in this disease. Regarding secondary outcomes, interestingly, you can see that we observed only 1 death in the triplet regimen. So only 1 death in the triplet regimen versus 12 deaths in the historical cohorts. So this difference was almost statistically significant. Here again, refractoriness was strikingly different, 1% in the triplet regimen versus 18% in the historical cohort. And exacerbations were rare in the triplet regimen, 3.4% versus 44%. And the remaining results show that we could observe a dramatic alleviation of the burden of care in these patients. So I will skip some slides to show you that this is the typical response of patients with our triplet regimen that includes plasma exchange, immunosuppression, and trastuzumab. You can see that this 45-year-old woman had a severe condition. She had TTP with cerebral and cardiac involvement. She had typical features of TTP, so we were confident in starting immediately the triplet regimen. And you can see that despite the severity of the disease, platelet count on the left improved nicely and durably. And on the right side of the slide, you can see that LDH level reflecting organ injury dropped rapidly and durably. And this patient is now well, while she was exposed to bad outcomes. So we clearly could, with the use of this triplet regimen, prevent bad outcomes in these patients. So I will skip this slide because regarding side events, we had no red light regarding the side events in comparison with the clinical trials. So I will skip the prevention of relapse, just to say that with the use of rituximab, we can now prevent most of relapses in these patients. Now we'll move to the conclusion directly. So with the triplet regimen, which associates adamantine supplementation with plasma exchange, and soon we hope with the recombinant adamantine, immunosuppression with corticosteroids and rituximab, and trastuzumab to inhibit the interaction between VWF and platelets, we dramatically improve the prognosis of the disease, since we observe almost no deaths in these patients and almost no exacerbations. So this triplet regimen is now the standard of care in France and in an increasing number of countries in the world. So this triplet regimen with the use of especially capacitizumab should still decrease the death rate at the acute phase of the disease. And once again, these new therapies, including capacitizumab, but also rituximab, derived from the understanding of TTP pathophysiology, are increasing the good prognosis of the disease. So with that, I will stop here to keep the time and thank all my colleagues who work with me on this topic in France and throughout the world. And thank you again for your invitation.
Thank you, Prof. Kopo, for this very extensive and elegant presentation. I think now we have time for a few questions. So we'd like to welcome Prof. Crowther again for joining us. And I will start with one question on, when to restart anticoagulants. This is for Prof. Crowther, after a major bleed in different indications. This is a very wide question and maybe by itself worth a 1 hour discussion, but a broad guidance, if you may, please.
Yep, thanks, Hazza. So it's a really important question, and in the long version of my talk, I actually have a couple of slides, one of which says, as soon as a patient is admitted to the hospital with a major bleed, you should include a plan for restarting anticoagulation. And the reason for that is really twofold. The first is most patients with a major bleed can have their anticoagulants restarted because most causes of major bleeds are actually amenable to treatment. It's not normal to have a major bleeding source. And so if it's a bowel cancer, or if it's a duodenal ulcer, or if it's a traumatic injury, in all those circumstances, you can restart anticoagulants. The second is that there's really good quality evidence now that if you take a group of patients who have a major bleed and don't have their anticoagulants restarted, and you take a matched group of patients who have a major bleed and who get their anticoagulants restarted, the group that restarts has a lower risk of death and a lower risk of recurrent thromboembolism, counterbalanced by a small increase in the risk of major hemorrhage. So, the large majority of patients should have their anticoagulants restarted at an appropriate time. So that's the key part of your question. Who should have their anticoagulants restarted? There's some patients who should not. People who have this amyloid angiopathy in their head, that's a cause of recurrent bleeds, a very high risk of recurrent bleeds. And there's a general consensus that people who have that abnormality should not have their anticoagulants restarted. That's a small group of people. Falls are not really a reason. If a person falls every single day, then you should intervene to try to prevent them from falling every day, not stop their anticoagulants. People falling every day suffer fractured hips and fractured arms and other traumatic injuries, which are avoidable by putting in place support mechanisms around to prevent them from falling. The second major question is when, and I would say in general, it's a lot earlier than people want to restart. So Dan Witt, who works in Utah, published a really nice paper at the ASH meeting a couple of years ago, and I would encourage people to look that paper up. His last name is Witt, W-I-T-T, where he looked at the available evidence after gastrointestinal bleeding and said the optimal time to restart after gastrointestinal hemorrhage is probably somewhere between 7 and 14 days. So, it is an hour-long talk all by itself, but to summarize, the large majority of patients can have their anticoagulants restarted, and most of those restarts can occur fairly early once the bleeding source is mitigated.
Thank you, Prof. Crowther. Now to colleagues, I honestly don't see the chat box for questions from audience, but I will ask a question to Prof. Kopo, please. There is an old trial on the Italian study on the use of aspirin in ATTP, and it was it was a good number of patients, I think in the 70s, with good outcome, even survival advantage. So are you using a very expensive antiplatelet compared to
Yes, thanks, Azar, for this question. There is a lot to say about aspirin in TTP. So years ago, it had sense to propose aspirin in these patients, as there is these patients have are prone to platelet clumping. So one could it had sense again to propose aspirin in this disease. However, trials showed that basically aspirin was associated with bleeding, and no clear advantage could be shown with the use of aspirin in these patients regarding improvement of organ damage and platelet count recovery. So 20 years ago, now it was stated that aspirin was not indicated frontline in this disease. And with the works of Joel Mock, we understood why aspirin was not so efficient in this disease. It is simply because the pathway by which platelets clump in this disease is the pathway involving VWF and GP1B. And this pathway is not targeted by aspirin. So this is why it doesn't work. On the opposite, caplacizumab is an anti-adhesive agent that is specifically able to block this pathologic interaction. So this is why it works much more than aspirin. And lastly, last years, it was shown that patients who recover an episode of TTP are more exposed to cardiovascular events, even if they completely recovered from their disease. And those patients are more exposed to cardiovascular complications, and they also have a shortened life expectancy because they experience various cardiovascular events. And this is true, especially in those patients who have a mild decreased Adamson activity. All of that to say that in the end, aspirin could find a role in the management of these patients after patients recovered from the disease to prevent cardiovascular events.
Great. Thank you very, very much. I think we only have time for maybe one or two questions for each. Dr. Crowther, if andexanet is readily available and at affordable costs, what would be the ideal scenario for its use in your judgment?
Yeah, that's an excellent and interesting question. I think I get asked this question a lot, and in Canada it's not available, and I don't foresee it being available because it's too expensive. In the US, it is widely available, and so I get asked this question very frequently by US centers because the full dose is about $50,000 and the half dose is about $25,000, and in most medical systems that's very expensive. So hospitals want to make sure that it's being used sensibly. Ideally, you would have a rapid test that would take minutes to get back, which would say that the person had a DOAC on board before you used andexanet, given its cost. Those things don't exist. So in Europe, as I mentioned in my talk, there is a dipstick that is actually quite reliable, that you can just dip into the person's urine, and if it turns a funny color, then that means it has rivaroxaban or apixaban. If it turns a different color, it means they have dabigatran. If you had that available to you, that would be extremely helpful, because it would tell you, first of all, whether the person had the drug on board, because you know about a quarter of people who say they have taken these drugs don't actually have detectable drug at levels that are clinically important. If you don't have access to that, then I think the obvious case is an intracerebral hemorrhage. A 28-year-old woman has a deep vein thrombosis, gets started on a direct oral anticoagulant, and presents 3 days later with that, because if you can prevent that bleed from progressing, you can reduce the morbidity associated with that bleed, and you'll save money over the person's lifespan. I think probably a limited number of other bleeds, maybe retroperitoneal bleeds where a person is hemodynamically unstable. Truly massive GI bleeds where the person is hemodynamically stable. I wouldn't, if it was much cheaper, you would use it a lot. But I think given its cost, you really have to be really careful to make sure you're using it when it's truly going to prevent death, rather than when it might just take a person's bleed from 6 units to 4 units. It really does need to be used in a person in whom you're going to prevent death or significant long-term neurologic morbidity.
Do you think it increased the risk of thrombosis?
Another good question. So when you give andexanet or idarucizumab, people do have thrombosis afterwards, but remember, they're all at increased risk of thrombosis. That's why they're on a blood thinner in the first place. If I had to estimate, I think that idarucizumab does not increase the risk above background. And I think that andexanet probably does increase the risk above background. I'm not particularly worried about that because we showed in our study that was published in the New England Journal that if you get them back on anticoagulants quickly, like your first question, you can completely get rid of that. And secondarily, it actually would be, and I think it's advantageous if the andexanet produces a little bit of a prothrombotic burst, because you're using it in people with major and life-threatening bleeding, and you want to get their coagulation system revved up. So it probably does produce a small increment in the risk of venous and arterial thromboembolism, but it's completely abrogated by appropriate use of early re-anticoagulation.
Great, thank you very much. There are many questions, and the night could end without finishing, but we'll, for the sake of time and your time, we will move to very quick practical questions to Prof. Coco. The use of SD plasma and the use of cryosupernated plasma versus regular plasma. What is your suggestion?
Yes, the solvent detergent plasma is the widely used in the management of TTP. The cryosupernatant plasma, much less. The rationale for the use of cryosupernatant plasma is that the highest VWF multimers have been removed. So there is a sense for the use of this agent, but basically studies failed to clearly show benefits for this plasma. So it is not routinely used in many countries, and moreover, many countries do not have access to this plasma. So I would say that it is very rarely used in this indication. So the plasma that are typically used in this disease are the solvent detergent plasma and the regular frozen quarantine plasma as well.
Prof. Coco, Prof. Crowther, we are very grateful to your time, and we really appreciate your presence with us. And I think this was a very successful activity. We had tonight 4,000 attendees, and if I may, Ella, if you can move the slides. We had in this annual Saudi Hematology Congress 2021, we had 33,888 registrants. Total attendees 22,997. 75 distinguished speakers, world-renowned authorities, very elegant presentations, and 61 lectures. We are very grateful to all your time and efforts, and we also very greatly appreciative of the support from sponsors, the drug companies. We had our platinum sponsor, Janssen, gold sponsor, AbbVie, Amgen, Astellas, and AstraZeneca, Bristol Myers Squibb, Gilead, Novartis, Sanofi, and Takeda. And all the silver sponsors are shown below: Biologics, Roche, Pfizer. I'm sorry, I cannot see some of them here, but we are very grateful to all the support we got from the audience, the speakers, and the organizers. And thank you all very much. And we're very grateful to you. We hope to see you next year. Bye-bye.
Thank you. Goodbye, Azar. Goodbye, Mark.
Thank you. Congratulations.
Thank you. Thank you. Thank you very much. Appreciate your time.